Hi, this is Brian Kim. I want to share with you case number 76 in the best way to do cataract surgery series. This is a patient with a dense lens, and you're going to see double chop, cross chop. There's an area of zonular dehiscence, and so you're going to see my atraumatic capsular tension ring technique using a Sinskey hook to hook the leading eyelet so that when the CTR dials into the bag, it's not causing significant torsional traction. So I'm using a cotton tip to hold the eye steady, and using a corneal marker to help me center and size the rhexis. I'm making my paracentesis incision first on the right side and then the left side. I make sure the incision is parallel to the iris plane, which will allow me to create a nice corneal shelf, which will allow me to achieve a self-sealing incision. I'm injecting some intracameral lidocaine and then some dispersive viscoelastic to fill the bag. This is a triplanar corneal incision. I make a vertical groove, place the blade into the deep part of the groove, tunnel, and then enter. I push some more viscoelastic in the eye. You can see there's a large PSC component to this cataract. I'm not able to do the puncture style rhexis, which does suggest that there's some zonular weakness to this patient. So I'm switching to the cystotome. I'm going to puncture the center, sweep to the left, and then pull down to get a flap. So I'm switching to the forceps now, grasping the flap, pulling it around counterclockwise. Again, this big PSC component makes it a little bit of a challenge to see the edge of the rhexis, but I'm able to follow it still. Just going around circumferentially again. Trying to keep the rhexis size and centration consistent with the previous corneal mark that I made. Okay, finish off the rhexis, burp some viscoelastic from the anterior chamber. This is the capsular fornix hydrodissection technique. I place the cannula under the rhexis edge out to the contralateral equator, point the tip down, get a nice wave, decompress on the left side, and then try to turn the lens, but it didn't really turn very easily. I'm sweeping some more on the left side, and then now on the right side. For some reason, it's wanting to rotate counterclockwise, so I'll go ahead and start rotating the lens counterclockwise. So I'm making sure the tip is the appropriate length of the sleeve. Irrigate the cornea. Lift the incision with the chopper, go in with irrigation off to minimize any decimase trauma. I place the chopper underneath the rhexis edge, point the phaco tip vertically sub-incisionally, bring both instruments together, and it breaks the lens in half. You can see there's quite a bit of force there to fracture the lens because of the density of the lens. Place the chopper around the right heminucleus, pulling it centrally towards the phaco tip, and I'm able to bisect the right heminucleus. So that is the double chop and cross chop respectively. I'm placing the chopper around that first quadrant, making sure I'm hooking it, and then crushing it, pulling it centrally towards the phaco tip, meeting the chopper with the phaco tip, crushing and dividing that quadrant, using a little bit of vacuum to remove some of that soft lens material, grasping the quadrant up, pulling it up with some high vacuum, then crushing it between the chopper and the phaco tip, and then emulsifying the lens pieces. Using a little bit of vacuum to try to grab that piece. It's not really wanting to come up. So I'm using the chopper to try to crack a little bit of the posterior aspect of the lens pieces. They're a little bit jigsawed together. Once I've separated the pieces, I can see, oh, there's still an adhesion there. You can see as I was turning the lens, there's quite a bit of zonular laxity there. I was trying to turn the lens there. So again, very dense lens, jigsawed together in the posterior aspect. I was able to crack that lens completely now. And then now I'll go ahead and separate and crush the second quadrant with the crushing force using mechanical fracturing techniques. Repositioning the lens piece with the chopper and then using high vacuum to grasp the lens piece, pulling it up, crushing it, and then dividing it between the chopper and the figure tip and emulsifying the lens pieces. Yeah, this is just a really dense lens. It's got some posterior adhesions. It's not really wanting to turn very easily. So the first half is out now. We deal with the second half. Place the chopper around the lens piece, pulling it centrally toward the figure tip. The figure tip is placed deep in the bag. I divide that heminucleus in half, place the chopper around the third quadrant, pulling it centrally toward the figure tip, and I'm able to divide that third quadrant. Very carefully separating that third quadrant from the rest of the mass there, and then I'm placing the chopper around the fourth quadrant and dividing and crushing that lens piece in half as well. I'm trying to tease off the deep attachments between each of the pieces of the quadrants there. I'm injecting some dispersive viscoelastic to coat the corneal endothelium here. Use a little bit of vacuum to grasp that piece, pulling it up, sandwiching the lens piece between the chopper and the figure tip, grasping it with some vacuum, crushing it between the chopper and the figure tip again, sandwiching it over and over again until they're smaller pieces, and then emulsifying the lens pieces. Grasping another piece with the figure tip using vacuum, and then again crushing it over and over until it's smaller, and then emulsifying the lens pieces. Using a little bit of vacuum to grasp that piece up, crushing it between the chopper and the figure tip, and then emulsifying the lens pieces. Using the chopper to mobilize that other piece there, hooking it, pulling it up, and then crushing it between the chopper and the figure tip, emulsifying the lens pieces as we go. Crushing again the lens between the chopper and the figure tip. And then emulsifying the lens pieces. I'm trying to use sparing amounts of ultrasonic energy as I break down this lens. I come out here because, one, I feel like the figure tip might be a little bit clogged. And so while My technician is trying to flush the tip. I'm just using a viscoelastic cannula to position that lens piece in a slightly easier place for me using the viscoelastic cannula. So I go in, again, lifting the incision with irrigation off, and then activating irrigation. Positioning the lens piece between the chopper and the fingertip, sandwiching it, and then emulsifying the pieces. All right, so we take the chopper out, push BSS in, take the phaco tip out, and go in with the INA handpiece. Start sub-incisionally, removing the sub-incisional cortical material from anterior to posterior. I'm still in the cortex mode here. Teasing off, oh, you saw that? As I teased up with the INA tip, the capsular bag on that side just collapsed into the INA tip. And so, I know that that is an area of zonular weakness. I don't believe that's iatrogenic because there was nothing specific that would have caused that to happen. And of course, in the beginning of the case, I couldn't do the puncture rhexis. The lens wasn't wanting to spin very easily. So in that area in particular, I don't believe there was any particular force applied on that right side. So very carefully, I remove all the cortical material in that area without causing too much traction on the capsular bag. I'm using the BSS cannula pulse the sub-incisional area of any lens material there. Now I'm filling the bag with cohesive viscoelastic, and now we're going to have to go to the capsular tension ring, and this is that technique I was telling you about. So I'm able to insert pointing down. I'm inserting it, grasping it on the left side so it rotates in counterclockwise, and so the CTR is going to dial out in a clockwise manner. You want to use the Sinskey hook to grasp the leading eyelet, and as you advance the CTR, it rotates, but since you're holding the diameter of the CTR smaller than the capsular bag diameter, it doesn't cause any torsional stress as it's delivered into the bag. Once the CTR is in the bag, I'm able to polish underneath the rhexis edge now more confidently, since there's equatorial support of the capsular bag with the CTR. After I widen the incision, I inject the 3-piece acrylic lens into the capsular bag with the bevel pointed to the left. I advance the leading haptic into the capsular bag, pointed to the left. As the optic comes out, you want it to come out planar, which means you have to rotate your wrist counterclockwise, and it allows the optic to come out flat. And then I'm dialing the trailing haptic into the bag with the Maltzman. So I go in with irrigation off, activate irrigation, remove the viscoelastic from within the bag. Remove all the viscoelastic from the anterior chamber. So again, this was a very dense lens. This patient had, again, inability to do the puncture style rhexis, which tells me that there was quite a bit of zonular laxity. And I was trying to spin the lens, and it was a little bit on the difficult side to spin the lens. For some reason, there was an area of zonular dehiscence. There was quite a bit of zonular dehiscence on the right side there. Again, with the dense lenses, you just never know how stable the zonules are. I like to use that technique where I use the injector, but using a Sinski, hooking the leading eyelet. As the CTR is being advanced, you're hooking the eyelet so that it twirls in a tight circle, smaller than diameter of the capsular fornix to minimize any zonular stress, and it goes in a very atraumatic manner. So I hope this was helpful to you, and I thank you for your attention.